Hi, good morning, doctors. Today we are on our 15th day of reading Oxford Handbook of General Practice. I am your study buddy, Dr. Sesha. We are preparing together for MRCGP International AKT exam, and this one we are starting on page number 367. Appendicitis and small bowel disease is a topic which we were reading yesterday, and we will continue today. Intestinal non-Hodgkin's lymphoma. The majority of the intestinal non-Hodgkin lymphoma are B-cell lymphomas, but celiac disease is associated with T-cell intestinal lymphoma. Abdominal symptoms: non-specific abdominal pain, perforation, bowel obstruction, abdominal mass, intussusception, malabsorption. Usually, lymphoma is associated with celiac disease, or lymphoma associated with celiac disease has malabsorption or alteration in bowel habit. Small intestine non-Hodgkin lymphoma may present like Crohn's disease. Systemic symptoms: weight loss, fatigue, sweats, unexplained fevers, lymphadenopathy, and hepatosplenomegaly are usually absent. So, other features of lymphoma like weight loss, 30% weight loss, fatigue, night sweats, unexplained fevers, all of these are present even in intestinal non-Hodgkin's lymphoma, whereas lymphadenopathy and hepatomegaly are absent. Management: gastric lymphoma may remit with the treatment of H. pylori infection. This is one important thing to know about intestinal non-Hodgkin lymphoma. Carcinoid tumors: slow-growing tumors of low malignancy which arise from the neuroendocrine cells or the precursors. Incidence is 3 in 4 of 1 lakh. Peak age is 61 years. Females more than male predominance. 60% are in the midgut, especially the appendix and the terminal ileum. Examination may reveal an abdominal mass or an enlarged liver. Rarely present with a bowel obstruction. Ileal carcinoids are multiple in 30% of the cases. Non-intestinal sites for carcinoid are lung, testis, and ovary. Carcinoid syndrome. It affects 10% of the patients with carcinoid tumor. Develops when the serotonin, that is 5-HT, is released from the tumor and not degraded by the liver due to hepatic metastasis. Okay, there are two conditions. When there is the tumor is producing one, it produces serotonin, and it is not metabolized by the liver due to hepatic mets. Features are paroxysmal flushing following alcohol or certain foods, watery explosive diarrhea, bronchoconstriction like asthma, abdominal pain, right heart failure symptoms, rash, symmetrical pruritic erythematous rash which blisters or crusts. Management: refer to urgent assessment if suspected. The therapeutic options include surgery, somatostatin analogues such as octreotide, or radiofrequency ablation of the liver mets. Prognosis: if no metastasis, median survival is 5 to 8 years. With metastasis, median survival is 38 months. Colorectal cancer screening. This is an important topic for us. Screening for colorectal cancer is available throughout the UK. Overall colorectal cancer survival, 5-year survival, is equal to 50%. Patient presenting with tumor confined to the bowel wall have more than 90% long-term survival. Screening aims to detect the colorectal cancer at an early stage to increase the survival chances. Screening test: fecal immunochemical test. Fecal immunochemical tests are set every 2 years to all patients aged 60 to 74 years with instructions of completion or return. Results are sent to the patient in less than 2 weeks. So every patient between 60 to 74 years, every 2 years we are screening with fecal immunochemical test. The screening by a one-off flexible sigmoidoscopy is being introduced gradually across England for all patients at 55 years. Screening outcomes: all those who have a possible fit test are invited for a colonoscopy pre-assessment appointment. Possible outcomes from colonoscopy are summarized in table 12.8. If 60% of those aged 60 to 69 years do the fit test, 1200 deaths will be prevented each year. That's a big number. Family history. If a patient has one first degree relative, mother, father, sister, brother, daughter, or son with colorectal cancer, risk of developing colorectal cancer is increased 2 to 3 times. Refer for colonoscopy. At presentation, excuse me. Refer for colonoscopy either at presentation or age 30 to 40 years, whichever is later, and repeat colonoscopy if age is 55 years. So when patient has presented or a patient with a family history, when they have presented or in between 30 to 40 years, uh, whichever in these two scenarios, whichever is later, and repeat colonoscopy if age 55 years. Two time, two first degree relatives with a history of colon cancer, one first degree relative with a history of colorectal cancer aged for less than 45. So this is for colonoscopy with people with family history, and then family history means for, two of the first degree relatives with a history of colon cancer or one first degree relative with a history of colorectal cancer aged less than 45 years. Refer for a specialist follow-up and genetic counseling. If more than two first degree relatives with a history of colorectal cancer or family history of familial adenomatous polyposis usually develop cancer aged less than 40 years, lifetime risk of colorectal cancer is 1 in 2.5. Juvenile polyposis, lifetime risk of colorectal cancer is 1 in 3. Peutz-Jeghers syndrome, autosomal dominant disorder, benign intestinal, usually small intestinal polyps in association with dark freckles on the lips, oral mucosa, face, palms, and soles may cause GI obstruction or bleeding. Malignant chain occurs in 3% of the cases. Hereditary non-polyposis colorectal cancer syndrome, that is Lynch syndrome. More than 3 family members with colorectal cancer where more than 2 generations have been affected and more than 1 family member developed the disease in less than 50 years of age. 40% lifetime risk of colorectal cancer. So most risky one is hereditary non-polyposis colorectal cancer or Lynch syndrome, in which 3 family members with colorectal cancer, 2 generations have been affected and 1 family member developed this disease in less than 50 years of age. So it is a 3-2-1 rule. MMR mismatch repair oncogene. MMR oncogene is present. So you have to refer for a specialist follow-up and genetic counseling if more than 2 first-degree relatives have a history of colorectal cancer or there is a family history of familial adenomatous polyposis, juvenile polyposis, Peutz-Jeghers syndrome, hereditary non-polyposis colorectal cancer, and MMR oncogene is there. Ulcerative colitis increases the risk of colorectal cancer. Offer the patients a follow-up plan agreed with their specialist. In some cases, prophylactic colectomy is appropriate. Previous colorectal cancer increases the risk of developing a second colorectal primary after successful treatment. Younger patients are routinely followed with colonoscopy every 5 years until 70 years. Remain vigilant for recurrences and refer urgently if suspected. Colonoscopy outcomes. So 2% of those with FIT tested are referred for colonoscopy. Uptake of colonoscopy is 80%. Sensitivity of colonoscopy to detect significant abnormalities is 90%. Polyps formed during colonoscopy are usually removed. Complications of colonoscopy include heavy bleeding in 1 in 150, bowel perforation 1 in 1500, and death 1 in 10,000. Colonoscopy result, explanation and action. If it is normal, as in 50% of the patients, no abnormalities are detected. Action, fit is screening offered again in 2 years if less than 70. So anyways in between, what was the age group? 74 I think. 50 and 74 you're offering fit screening. In between 60 and 74 years, you are offering fit screening every 2 years, and in case the fit is positive, you are sending for a colonoscopy, and if colonoscopy is normal and fit was abnormal at that time, right? So then fit screening is offered again if in 2 years if it is less than 70 years. Polyp is present in 40% of the cases. Low risk cases, 1 to 2 small adenomas are present, less than 1 centimeter adenomas are present. Fit screening offered again in 2 years if less than 70 years. Intermediate risk, 3 to 4 small, less than 1 centimeter adenomas or more than 1 adenoma more than 1 centimeter. So less than 1 centimeter and 1 to 2 are there, then it's low risk. Intermediate risk is 3 to 4 and less than 1 centimeter, or even more than 1 adenoma is more than 1 centimeter. A 3-yearly colonoscopy until 2 negative examinations are found. You have to redo the colonoscopy after 3 years, every 3 years until 2 negative examinations are found. High risk, more than 5 adenomas or more than 3 adenomas of which at least one is more than 1 centimeter. Colonoscopy at 12 months, then 3-yearly colonoscopy until 2 negative examinations is there. So in high risk cases, colonoscopy at 12 months first, and then you are repeating a colonoscopy at 12 months and then 3-yearly colonoscopy until 2 negative examinations. Cancer in 10% of the cases. Colorectal cancer detected at colonoscopy, refer urgently for treatment. Other pathology at colonoscopy. Other pathology, you have discovered ulcerative colitis detected at colonoscopy, refer for test, refer, treat, advise as necessary. Technical difficulty, unable to perform the procedure adequately, repeat the colonoscopy or alternative imaging test. Fit testing for symptomatic patients. Fit tests should be offered to adults without rectal bleeding who are aged more than 50 years with unexplained abdominal pain or weight loss, or aged less than 60 years with changes in bowel habit or iron deficiency anemia, aged more than 60 years with anemia without iron deficiency. So anemia of chronic disease also, if he is aged more than 60 years, you have to send for fit testing. Age less than 60 years, the changes in bowel habit or iron deficiency anemia is present. Age more than 50 years with unexplained abdominal pain or weight loss. Colorectal cancer. The lifetime risk, page number 370. The lifetime risk of developing colorectal cancer is 1 in 15 for a female and 1 in 19 for a male. Colorectal cancer accounts for 14% of all the cancers and 16,000 deaths per year in the UK. 2/3 arise in the colon, 1/3 in the rectum. 72% of tumors occur in the patients more than 65 and more than 95% are adenocarcinomas. Adenomatous polyps. Bowel cancers can arise from polyps for many years, long-standing polyps. Polyps have been removed because of risk of malignant change, may be removed. Follow-up surveillance with repeated colonoscopy may be necessary depending on the number of polyps and the size. That we have already seen in 12.8. Protective risk factors. Lifestyle factors. Obesity. Obesity increases the risk by 15% if overweight and 30% if obese. Obesity. Dietary factors. Diets with less red and processed meat and more vegetables, fiber, fish, milk are associated with decreased risk. Diet thought to explain geographic variations. Alcohol. Increased risk for heavy drinkers, especially if also low folate is there. Physical activity. Increased physical activity can decrease the risk by 30%. So obesity, dietary factors, alcohol intake and physical activity are lifestyle factors. Medication history. HRT. Risk decreases by 20% even if ever taken HRT and decreases by 30% if they are concurrently taking HRT. COC pills. Risk decreases by 18% if ever they have taken COC pills. Statins. Risk decreases after 5-year use. Aspirin. 75 per milligram OD taken for more than 5 years. Risk decreases by 40%. Okay. Other medical history. Gallbladder disease or cholecystectomy. 50% increase in risks. Whenever you have a gallbladder disease or cholecystectomy history, there's an increased risk of up to 50%. Type 2 or non-insulin dependent diabetes, 30% increased risk. Ulcerative colitis or Crohn's disease, the risk is increased. Family history, if present, the risk is increased. Bowel cancer screening 368. Presentation may be found at bowel cancer screening. Clinical presentation depends on the site involved. If there is a change in bowel habit, there is diarrhea plus mucus, constipation or alternating diarrhea and constipation, and tenesmus. Intestinal obstruction. Pain, distension, absolute constipation plus vomiting may be an acute or sudden onset event. 20% patients not detected by screening present with an acute obstruction or gradually evolve. Rectal bleeding. Bright red rectal blood or positive fecal occult blood test. 60% of rectal tumors, rarely melena if high tumor. Perforation. Causing generalized peritonitis or into adjacent viscous, example a bladder, resulting in a fistula. Spread. Abdominal distension secondary to ascites, jaundice, rectal or pelvic pain. General effects: weight loss, anorexia, anemia, and malaise. Examination and investigation. General examination: cachexia, jaundice, anemia. Check the FBCs. Abdominal mass is present. Hepatomegaly, ascites. Rectal examination detects 75% of the rectal tumors. Suspicious lower GI symptoms and signs. Refer urgently to be seen within 2 weeks to a team specializing in lower GI malignancy. Any age. Rectal or abdominal mass consistent with involvement of the large bowel. A pelvic mass outside the bowel warrants urgent referral to a urologist or a gynecologist. Rectal bleeding and abdominal pain or change in bowel habit, weight loss or iron deficiency anemia. So there should be rectal bleeding and along with either abdominal pain or change in bowel habit or weight loss or iron deficiency anemia. And if you are aged more than 40 with unexplained weight loss or abdominal pain, age more than 50 with unexplained rectal bleeding, age more than 60 with iron deficiency anemia or changes in bowel habit or tests showing fecal occult blood in their feces. So more than 60 with iron deficiency, change in bowel habits or tests showing fecal occult blood. You have to refer directly to a lower GI team specialized within 2 weeks cancer referral to a team specializing in lower GI malignancy. Specialist management. Confirm the diagnosis with sigmoidoscopy, colonoscopy or CT colonography. CT colonography. So once you are sending to a specialist in lower GI cancers, what they will do? They will do either a sigmoidoscopy or a colonoscopy or a CT colonography. If diagnosis is confirmed, further investigations include LFTs, tumor markers for colorectal cancer, carcinomic antigen. CEA is produced in more than 80% of advanced tumors. They do a chest X-ray for metastasis, CT or MRI and ultrasound to evaluate the spread. Treatment: laparoscopic or open surgical resection when possible. Staging based on findings at surgery dictates further management with chemotherapy. For patients with more advanced disease, resection or radioablation of the hepatic metastasis may be an option. Adverse pathological features, adverse clinical features, presence or number of involved lymph nodes, uh, presence or number of involved lymph nodes, lymphovascular, perineural or venous invasion, depth of the bowel wall perforation, positive resection margin, mucinous histology. If there is a mucinous histology, then it is adverse pathology. Adverse clinical features, emergency presentation with a bowel obstruction or perforation. When the patient is presenting in emergency like this, incomplete resection is there, metastatic disease is there, presentation age is less than 50 years. So then it is adverse presentation. Patient advice and support is on page numbers is in their website. 372. Other large bowel conditions. Intestinal obstruction. Blockage of the bowel due to either mechanical obstruction or failure of peristalsis or ileus. Causes are obstruction from outside the bowel due to adhesions, bands, volvulus, obstructed hernia, neighboring malignancy of bladder, obstruction from within the bowel wall, whether there is a tumor in the bowel wall, infarction, congenital atresia, Hirschsprung's disease, inflammatory bowel disease, or diverticulitis. Inflammatory bowel disease like Cornscott strictures and diverticulitis. Obstruction in the lumen, impacted faces or constipation, bolus obstruction examples swallowed foreign body, gallstone ileus or intussusception or large polyps. This is when obstruction is from inside the lumen. And ileus or functional obstruction postoperatively, electrolyte disturbances, uremia, diabetes, back pain, anticholinergic drugs. Presentation of bowel obstruction, large bowel obstruction. Anorexia, nausea, vomiting, may be feculent, gives relief. Colicky, central abdominal pain and distension. Absolute constipation for stool and gas. Though if high obstruction, constipation may not be absolute. Examination. Uncomfortable and restless, abdominal distension, tenderness, though no guarding or rebound is present. Active tinkling bowel sounds or quiet or absent bowel sounds later. There could be distension, tenderness, and tinkling sounds or quiet or absent bowel sounds. Management, admit as an emergency. Bowel obstruction, admit as an emergency. Diverticulosis. Common condition of the colon associated with muscle hypertrophy and increased intraluminal pressure. Mucosa-lined pouches are pushed out through the colonic wall, usually at the entry point of the vessels. These pouches are the diverticula. 95% are the sigmoid colon, although they may occur anywhere in the bowel. They are present in 1 in 3 people and people more than 60 years in UK. Risk factors include low roughage in the diet and age. Diverticular disease implies diverticula are symptomatic. So this is diverticulosis, and then diverticulitis is when the diverticula are symptomatic. In table 12.9, ischemic bowel, interruption of blood supply of the bowel. Primary ischemia, usually due to either mesenteric embolus from the right side of the heart or a venous thrombus, mesenteric embolus from the right side of the heart, or a venous thrombus, and typically occurs in elderly patients who might have pre-existing heart or vascular disease. Secondary ischemia, usually due to intestinal obstruction, strangulated hernia, volvulus or intussusception. Okay. Presentation. Sudden onset of abdominal pain which rapidly becomes severe. There may be prior history of pain worse after meals, mesenteric angina. Rarely patients present with PR bleeding, per rectal bleeding. Examination very unwell, shocked. Maybe atrial fibrillation, generalized tenderness but normally no guarding and rebound. Often signs are out of proportion to the symptoms. Management. Give opioid analgesia. Admit as a surgical emergency. Sigmoid volvulus occurs in people who have redundant colon on a long mesentery with a narrow base. The sigmoid loop twists causing intestinal obstruction. The loop may become ischemic. Risk factors are constipation, laxatives, tranquilizers. These are risk factors for sigmoid volvulus. Presence with acute onset abdominal distension and colicky abdominal pain with complete constipation and absent flatus. There may be history of repeated attacks. Management. Admit acutely to the hospital. Treatment is by releasing by passing flatus tube or surgery. Once treated, the recurrences decrease the recurrences by preventing constipation and stopping tranquilizers if possible. Presentation and management of a diverticular disease. Chronic diverticulitis, painful diverticular disease. Presentation. Presence with altered bowel habit, abdominal pain, often colicky, and left-sided abdominal pain, nausea and flatulence. Symptoms are often improved by defecation. Investigate for change in bowel habit. Once diverticular disease is confirmed, treat with high fiber diet plus antispasmodics, example mebivarin 135 mg TDS. Refer if symptoms are severe. Acute diverticulitis. Present with altered bowel habit, colicky left-sided abdominal pain may become continuous and cause guarding and peritonism in the left iliac fossa, fever, malaise and nausea, flatulence. There may be few abdominal signs in the elderly. Treat with oral antibiotics, example, because it's an acute infection and diverticulitis. So treat with coamoxiclav 250 milligrams TDS or cefaclor 250 milligrams to 500 milligrams TDS and metronidazole 400 milligrams BD or ciprofloxacin 500 to 750 milligrams BD. So either coamoxiclav, cefaclor, metronidazole, ciprofloxacin. There may be some benefit from low residue diet. If so, this is low residue or low fiber diet. If severe symptoms, uncertain diagnosis or not settling, admit as an acute surgical emergency. Acute diverticulitis, first treat with antibiotics, low residue diet, and if not symptoms are severe or uncertain, not settling, admit as an acute surgical emergency. When there is a diverticular abscess, presence with swinging fever, general malaise, or other localizing symptoms, example pelvic pain. Refer for urgent surgical assessment or admit as a surgical emergency. Perforated diverticulum. This swinging fever we always see whenever there is a localized abscess in the body. Perforated diverticulum. Presence with ileus, peritonitis and shock. Admit as an acute surgical emergency. Fistula formation. A fistula may form if diverticulum perforates into the bladder, the vagina or into the small bowel. Refer for surgical assessment. Treatment is usually surgical. Diverticular hemorrhage. Common cause of rectal bleeding, usually sudden and painless. Gain IV access, admit as an acute surgical emergency. Post-infective stricture. Fibrous tissue formation following infection can cause narrowing of the colon or obstruction. Keep the stool soft. If recurrent problems, refer for surgery. Hirschsprung's disease. Caused by absence of ganglion cells in the myenteric plexus of the distal bowel, presence with delay in passing meconium, abdominal distension, vomiting and poor feeding in a neonate. If only short segment is affected, presentation may be much later with chronic constipation. Diagnosis is confirmed with rectal biopsy. Refer to surgery. Treatment is surgical removal of the affected area of the bowel. So carcinoma of the colon we have already seen. Anal conditions, inflammatory bowel disease we will see now. Anal conditions and perianal problems. Hemorrhoids and piles, common in all the age groups from mid-teens onwards, represents distension of the submucosal plexus of veins in the anus. Three main groups are situated at 3 o'clock, 7 o'clock and 11 o'clock positions. Relative to the patient viewed in lithotomy position, risk factors. Constipation is a risk factor for hemorrhoids. Family history of hemorrhoids, varicose veins, pregnancy and increased anal tone, cause is not understood, pelvic tumor or portal hypertension. Classification of hemorrhoids, first degree, piles remain within the anal canal. Second degree, prolapse out of the anal verge but spontaneously reduced. Third degree, prolapse out of the anal verge, requires digital reduction. Fourth degree, permanently prolapsed. Presentation. Discomfort or discharge plus fresh red rectal bleeding, blood on toilet paper, coating stool or dripping into the pan after defecation. So this is blood after defecation. A feeling of incomplete emptying of the rectum and mucus discharge is there, pruritus ani. Rectal examination, prolapsing piles are obvious, first degree piles are not visible or palpable. Management. If piles are not obvious on examination, arrange a proctoscopy plus sigmoidoscopy for all patients more than 40 years. So proctoscopy as well as a sigmoidoscopy. Treatment. Soften the stool. Bran, isabgol husk and recommend topical analgesia, lidocaine 5% ointment or OTC preparation. If not responding to treatment, uncertainty over the diagnosis or severe symptoms are present like soiling of underwear, refer for surgical assessment. Complications are strangulation. Circulation to the pile is obstructed by the anal sphincter, results in intense pain and anal sphincter spasm. Treat with analgesia if severe pain or symptoms are not settling, and admit. Thrombosis of the pile. Pain or anal sphincter spasm, analgesia, ice packs, and bed rest. Consider referral for surgery to prevent recurrence of thrombosis. Perianal hematoma or thrombosed external pile. Due to rupture of superficial perianal vein causing a subcutaneous hematoma, presents with sudden onset of severe perianal pain. A tender 2 to 4 mm dark blue berry under the skin adjacent to the anus is visible. Give analgesia. Settle spontaneously over 1 week. If less than 1 day old, can be evacuated via small incision under local anesthesia. Perianal hematoma or thrombosed external pile due to rupture of superficial perianal vein causing a subcutaneous hematoma. Present with sudden onset of severe perianal pain, a tender 2 to 4 mm dark blue berry under the skin adjacent to the anus is ever visible. Give analgesia, settle spontaneously over 1 week. If less than 1 day old, can be evacuated via small incision under the LA. Rectal prolapse occurs in two age groups, very young and those more than 60, present with the mass coming down through the anus plus anal discharge. In adults, there are two types, mucosal prolapse, adults with third degree piles. The bowel musculature remains in position but redundant mucosa prolapses in the anal canal. Complete prolapse, descent of the upper rectum into the lower anal canal, usually due to weak pelvic floor from childbirth. Bowel wall is inverted and passed out through the anus, may be associated with a uterine prolapse. Refer for surgery. Supporting ring may be used if unfit for surgery. Anal fissure. Anal mucosa is torn, usually on the posterior aspect of the canal, may occur at any age, present with pain on defecation, plus constipation, plus fresh rectal bleeding, blood on the toilet paper. So, can be present as pain on defecation, constipation, or fresh rectal bleeding. The fissure is often visible as a sentinel pile. Bunch up of mucosa at the base of the tear. Rectal examination is very tender due to muscle spasm. Management of an anal fissure. Stool softeners, esophageal husk. Try analgesic suppositories plus cream, syncocaine or hydrocortisone. If unsuccessful, add a glyceryl trinitrate 0.4% ointment BD which relieves the pain spasm but may cause headache. Okay, there's a GTN 0.4% ointment which you can give for application. 2% topical diltiazem cream BD is a third line option, but this is unlicensed in UK. So if interventions fails, refer for surgical review. Perianal abscess, usually caused by infection arising in the perianal gland, tends to lie in between the internal and external sphincters and points towards the skin at the anal margin. May affect patients of any age and presents with gradual onset of perianal pain, which becomes throbbing and severe. Defecation and sitting are painful. Characteristically, patients sit with one buttock raised off the chair. Examination, abscess is in the skin next to the anus. Refer as an acute surgical emergency for drainage. Perianal fistula. Abnormal connection in between the lumen of the anus or the rectum and skin. Usually develops from perianal abscess. Fistulae are either high fistula open into the bowel above the deep external sphincter or low open into the bowel below the deep external sphincter. High fistulae are rare and usually due to ulcerative colitis, cholestasis or a tumor, and they are more complex to repair. Presence with persistent anal discharge or recurrent abscess. The external opening is usually visible lateral to the anus and the internal opening may be palpable on rectal examination. Refer for surgical repair. Pilonidal sinus. Obstruction of a hair follicle in the natal cleft. The ingrown hair triggers a foreign body reaction. There is pain, swelling, abscess and fistula formation plus or minus foul smelling discharge. Refer for surgery. Pruritus ani. Itching around the anus occurs if the anus is moist or soiled. Example, poor personal hygiene, anal leakage or fecal incontinence, fissures, nylon or tight underwear. Other causes are dermatological conditions. Example, there is contact dermatitis or lichen sclerosis. Threadworm, infection, anxiety or other causes of generalized pruritus are there. Treat the cause if possible. Avoid spicy food. Moist wipe post defecation. Threadworm. Common in the UK, especially in children, Enterovias vermicularis causes an anal itch as it leaves the bowel to lay egg on the perineum. Often seen as a silvery thread-like worms at the anus of the children. Treatment: mebendazole available OTC. Treat the household contacts as well as the index case. Anal ulcers. Rare. Consider Cons disease syphilis tumor. Usually rare, and if there is an ulcer you consider either there is a Cons disease, syphilis or a tumor, and refer for anal ulcers. Anal cancer. Usually squamous cell cancer. Risk factors are anal sex, syphilis, anal warts, HPV, presence with bleeding, anal mass or ulcer, pruritus, stricture, change in bowel habit. A mass may be palpable on rectal examination. Check for inguinal lymph nodes. Management. Refer for urgent surgical review and confirmation of diagnosis. Treatment is usually with a combination of radiotherapy and chemotherapy. Abdominoperineal resection is reserved for salvage therapy after chemo or radiotherapy failure. So abdominal perineal resection is definitely a surgical treatment, but it is only reserved for salvage therapy after chemo or radio failure. Otherwise, chemotherapy and radiotherapy are the treatment for anal cancer.